Welcome to the Healing My Parts podcast, a podcast dedicated to educating and raising awareness about dissociative identity disorder, also known as DID. We are your hosts, the system behind Healing My Parts, which also includes parts that function as a therapist and leader in a mental health niche space. We'll be sharing tips and tools that have helped us and many others, while also sharing insights from our own journey of living with the condition. We'll also be hosting guests for conversations to help educate, dispel myths, and most especially help those living with dissociative identities and professionals who treat the condition. Thank you so much for tuning in. And now, let's get healing. Hello and welcome to episode 9 of Healing My Parts podcast. We are your hosts, the system behind Healing My Parts, which includes parts that work together as a therapist and leader in a mental health niche space. So we thought we would spend today talking about screening for DID and OSDD. A couple of weeks ago, we were blessed enough to be able to do a presentation and training along with a dear friend of ours about the intersection of DID and eating disorders. And part of that talked about kind of clues and things to look out for when you're screening for DID and OSDD. I happened to notice some feedback where somebody had said, I wish I had been told how to screen for DID rather than just being told to screen for it. And we did actually include how to screen for it in the presentation, but there was also a lot of information there. And it's completely understandable and reasonable how that might have been missed by one of the participants. And when we were thinking about it, we thought this was a pretty good opportunity to be able to just do a podcast about how to screen carefully. And that is something that can be helpful for people who suspect that they're systems, as well as therapists who are trying to treat people who are systems or who think that they might be a system. So I figured we would go through some of the ways of screening for dissociative identities that can eventually lead to a diagnosis or that may lead to a more immediate diagnosis. Let's start with formal instruments. There is something called the Dissociative Experiences Scale 2 or the DES2. This is not a diagnostic instrument, but rather a screening tool. It's freely available online, and we will include the website in the show notes so that anyone can click on it and take it. It's a good tool for understanding the potential level of dissociation that's present. And if you scroll all the way to the bottom, you'll see a grid there that shows average scores that correlate to certain diagnoses like eating disorders or anxiety disorders, PTSD, DID, and so on. There have been suggestions that scores over 60 tend to correlate with people who might be over-reporting or trying to sort of get a DID diagnosis, but they don't really have DID, or somebody that might be overly attached to the diagnosis. For more information on that, I really encourage you to check out Multiplicity and Me's YouTube video, which I will link also in the show notes. I also want to clarify that just because there is some information out there that says scores over 60 tend to correlate with people who may not have DID, doesn't mean that if somebody receives a score over 60 that they definitely don't have it. I encourage you again to watch Multiplicity and Me's YouTube. They also have some links in there to some really great articles on the potential for factitious disorder, etc. We also have that linked in a previous blog article that we did on Substack, and I can link that as well. Let's pause for a moment just to acknowledge that factitious disorder, faking DID is pretty rare. DID and OSDD are not rare. Again, 1 to 1.5% of the population globally has DID. 4.2% has OSDD1, which looks like DID. There's usually just something missing. Together, that is anywhere from 5.2 to 5.7%. It is equivalent to the global prevalence of depression. So DID is out there, OSDD is out there. Simply because we just mentioned the term factitious disorder or people who might be quote unquote faking it does not mean that that is common at all. It is not, but there is information out there for you, should you wish to explore it further. Now, moving along into tools that can be more diagnostic. One that is pretty well known is the Multidimensional Inventory of Dissociation, that is called the MID for short. It's a validated, reliable 218 item self-report inventory. It's really helpful when a clinician's serving client populations that are at risk for complex trauma, and it is a tool that's used by clinicians and researchers worldwide. Now, the mid analysis and the interpretive manual that go with it are actually completely free for use by any trained mental health professional or researcher that wants to basically better understand dissociation or dissociative processes, particularly from the point of view of the person experiencing them. So the MID has a bunch of bonuses to it. The analysis report is automated, it's on an Excel spreadsheet, and it really provides the treatment professional with generated scales, scores, correlates, diagnoses, and a whole lot more without the need to engage in this kind of laborious calculation process that some other inventories necessitate. So it comes with a really easy to use manual to interpret scores if you're just starting out and you're not really clear on what symptoms might mean. The MID is also known for being pretty adept at picking up some personality disorders, particularly BPD. It's good at diagnosing PTSD, the dissociative subtype, also OSDD, some somatoform disorders, and it's also able to identify when a client might be overly attached to the DID diagnosis. And all of that is detailed in an automated report. The detail of the report itself is incredibly impressive, showing you diagnostic suggestions, score elevations, and also suggesting to you when it might be prudent to further investigate certain areas. So, like, you'll find bar graphs and line graphs so you can see where the individual client falls in relation to kind of larger populations of people who share a DID diagnosis or OSD diagnosis or BPD diagnosis, as well as people who are non-dissociative, or at least not dissociative to a degree that would require a diagnosis. So it has many, many different subscales in it, just to kind of give you an idea of what the report looks like so that you can understand how detailed it is. I'm just going to kind of start at the top and give you a few examples. So the very top is when you will get impressions from the DSM. So you'll learn that maybe the person has PTSD dissociative subtype or some type of quote unquote pathological dissociation like DID or OSDD. It will target anything like potentially somatization that might be elevated or clinically sub-elevated. It'll let you know if there are any clinically significant BPD traits there, or it will even tell you that there are no traits reported. It will tell you what the indications are based on. So, for example, it might say something like a mean mid score of 41 to 64, some cases of PTSD, many cases of DID, and some test takers with problematic BPD features fall into this range. It will tell you if there's defensiveness or minimization that seems to be elevated. And if it is, it will tell you to examine the criterion A, B, and C symptoms and the diagnostic and clinical summary graphs to give you some context. The really cool thing about the report is that it does come with the line graphs and the bar graphs, so you can see where your client is and you can ask more questions to clarify what's going on. So it will also tell you things like, quote, no elevation is evident in the I have DID scale relative to the I have PART scale. If it's flipped the other way around, it will suggest that your client could be overreporting or might be attached to the diagnosis. That doesn't mean they don't have it. It just means that it's something for you to explore with them. It will give you the validity and characterological scales. It'll tell you what the pathological dissociation scales are. There's 31 amnesia items. It will tell you how many that your client has reported. There's 168 severe dissociation items that will tell you also how many your client has reported, and it will give you the number of criterion A, B, and C symptoms and how many your client reported. It will give you critical items and functionality and impairment. So criterion A is general post-traumatic dissociative symptoms. Criterion B is partially dissociated intrusions, and criterion C is fully dissociated actions or amnesia. And then if you go down, you get actually an extended mid report that will show you how your clients rated themselves using the 1 to 10 scale. It will give you the question number, it will give you the questions so that you can better understand on each of the scales, whether that's emotional suffering, attention seeking, a BPD index. There's dangerous persecutory voices or fugues, dissociated self-injurious behavior, cognitive distraction. There's a memory problem scale. There's so many scales here. It's really, really rich with information. Again, even if you're brand new, the information that you can get from this inventory can be really invaluable. Okay, that said, it's 218 questions. It's really long, it's really fatiguing. And if you are an individual who has dissociative identities, it's not that easy to do. If you have co-consciousness or you are aware of your parts, you might be trying to take this and find that multiple parts are disagreeing with which number on the scale to select because you have to pick between 1 and 10. And you theoretically can also select 0. If you have ever experienced a symptom, you can't select 0. And parts can disagree about what is the most accurate number to reflect your experiences. Now, what's interesting from a perspective of somebody with dissociative identities is that depending on which part is answering the question, you can get different answers. So a part might experience something to, whenever they're fronting to a large degree or frequently rather, versus another part that may not even be aware of it, so might score it as like a 0 or a 1 or a 2. You might also have only one part that shows up to take inventories like this, and that part may not be aware of all of the experiences within the system. That can also skew results. The mid won't necessarily show that. You may choose to give it more than once and have different parts show up to take it, which will give you vastly different scores. That's something to consider. So that is just an overview of the mid. Another diagnostic tool or screening tool is the structured clinical interview for DSM dissociative disorders, also known as the SCID-D. It costs about $92 for a pack of 5 interviews. So it's not exactly inexpensive depending on how many clients you want to give this to. It is described as an interactive, semi-structured interview for assessing dissociative symptoms and disorders in adults and adolescents. It's based on Dr. Marlene Steinberg's 5-component model of dissociation, which is amnesia, depersonalization, derealization, identity confusion, and identity alteration. It has about 30 years of research and clinical use that proves its reliability and validity, and it's been proven that that stretches universally across all cultures. Comes with a manual, comes with a pack. I will link more information about that in the show notes. There's also the Dissociative Disorders Interview Schedule, which is a 132-item interview, and that helps to diagnose DSM-5 dissociative disorders, as well as other conditions like borderline personality disorder, major depressive disorder, somatic symptom disorder. The DDIS also asks about childhood abuse, substance abuse, psychotic symptoms, and more. It was developed by Dr. Colin Ross. It's available online as an educational tool. However, in terms of getting a clinical diagnosis out of that, it's important to understand that a diagnosis can only be made by a trained mental health professional. So when I link this in the show notes, anybody can take it. You're going to find all of the questions there. So if you're somebody with DID or OSDD or think that you might have one of those diagnoses, you can go through this inventory. The terms of use for this particular instrument, I believe, state that when you use it, you're agreeing that only a trained mental health professional can give you a diagnosis based on the contents of the inventory as you take it. The DDIS is divided into 16 different sections. Each one is scored independently, and then the DSM-5 diagnoses are made based on those separate scores. Again, I will link the instrument in the show notes so that you can take a look at it, play around with it, and see what you think. So any of these diagnostic/screening tools can be really helpful. I think it's really important to note, though, that the individual person's ability to self-reflect and be aware is going to influence their performance and their scores. Which parts show up or which part shows up is also going to influence the scores. Parts can get really nervous about taking formal inventories. They may have rules around what they're allowed to divulge and what they're not allowed to divulge. They may have a gatekeeper who will refuse to share information and or a gatekeeper that can prevent the participation of other parts who might have more awareness or knowledge of what happens in the system and for the system. There might be parts that are just plain old scared to tell the truth. There may also have been parts that have been coached in what to say. For example, they may come from a family who might have a psychologist in the family who may be aware of some of the abuse that's going on, might be aware of the person's symptoms, and may give them instructions to, quote, never say X, Y, or Z on any instrument. Never, for example, never divulge that you hear voices. Never divulge abuse. Never make it up. Just don't tell people that you can't remember things. There can be all sorts of ways in which people have been coached. And this opinion is likely to ruffle some feathers, but there are many reasons why you might get a skewed score the first time or two. So honestly, clinical observations can be far more helpful than formal instruments. That's the opinion that's probably going to ruffle some feathers. The clinical observations that you have in sessions with your clients can tell you more over time than the diagnostic instruments or the screening instruments can. Let's think about that for a second. Whenever we have a formal instrument or a test that we might be giving somebody, testing can automatically make somebody more nervous. And what happens when we are more nervous? It's harder for us to think clearly. It's harder for us to access information. Our frontal lobe is not functioning at its very best. That alone can impact scoring and answers. It's also typically given in a 1 or 2 sessions versus when we're developing a relationship with somebody over time. The defenses of that system are going to start coming down. And if we are observant and we are curious, we are going to start noticing subtle shifts and changes that can clue us into a dissociative disorder being present that might not have been reported on a more formal instrument. Also, some of you might be thinking, well, why don't we just give our clients these instruments a couple of times? Because really they're long and fatiguing. And it also tends to make people feel like you don't believe them, that they have to prove their diagnosis if they happen to suspect that they have it. And if they don't, it can also make people really self-conscious. So using some of the good clinical skills that we have around observation and relationship building over time can give us the best information there is. What kind of things can a therapist look for in sessions or across sessions that can help identify DID or OSDD? So glad you asked. Plenty of things. So when you have a client, for example, who has never had a medication work, and they've tried many of varying different types and usually for various different diagnoses, but none have ever given them symptom relief or definitely has not given symptom relief in the long term. So antidepressant medications have not been helpful. Anti-anxiety medications don't seem to touch anxiety. Antipsychotic medications have been prescribed. People who aren't sleeping even though they're given medication specific to sleep. A lot of times clients with complex dissociative disorders will come in with a really long list, sometimes double-sided list of dates and medications and multiple different dosages, and will just be like, I'm so frustrated, nothing ever works for me. Here's a whole list of stuff that I've been on. When that happens, think dissociation. You might also note that the client has multiple different types of treatments that have been unsuccessful. So they've tried CBT, DBT, ECTs, they've tried ketamine, they've been in hospitals, partial hospital programs, IOP programs, and nothing has ever helped them get more sort of control over their day-to-day life or symptom relief. You might find that the clients come in with a laundry list of diagnoses. The most common things that people who have DID or OSDD tend to be diagnosed with are eating disorders, substance use disorders, major depressive disorders, OCD, schizophrenia, borderline personality disorder, and bipolar disorder. You might see all of those, a combination of those, Really not uncommon to see any or all of those. That was certainly an experience that we had. So, again, when you see these things, think dissociation. Another clue that someone may have DID or OSDD is confusion felt by the treatment team. So, members of the treatment team might be disagreeing on diagnoses, they might be confused about the diagnostic picture in general. They might also be confused by the presentation of the individual. Treatment team members might get together to discuss the individual and find that they all disagree on what they're seeing. That might be a result of different parts presenting to different providers. You may see some inconsistent reporting as well as inconsistent presentations. And very often, whenever a client comes in with an inconsistent presentation or inconsistent reporting, it's really interesting that many providers will default to accusing the client of being attention seeking or manipulative. That tends to come up before providers consider that maybe there's some dissociation going on and maybe there are different parts present. Very often you will find inconsistent reporting or presentations, or you might find clients who compensate for that really well by keeping extensive lists so that they might be checking those before they come into sessions to make sure that they're presenting as consistently as possible, but it's a lot of work for them to be able to do that. You also want clients to be as authentic as possible in sessions so that they can feel comfortable enough allowing their parts to come out. That will make your job a whole lot easier. Another clue that you can screen for in your sessions over time is looking at clients who appear to be doing really well at both work and school, but they're regressing in therapy. So the two things don't match up. They're able to do some work in therapy. They're struggling symptomatically. They're not looking as fluid, and yet they seem to be functioning perfectly fine at work or school. Likely because there are two different parts present. There's a part that's going to work in school and is able to not be aware of what's going on in therapy. That's what allows them to function. And then you have the part that shows up in therapy doing the work that's experiencing the regression and experiencing a lot of distress that isn't really all that aware of what's going on at work or school. Be also aware of somatic symptoms in your clients. So if there's unusually high pain tolerance, that is something I'm happy to share that we have experienced, or as far back as I can remember. I can have injuries, don't even know that I've injured myself because I don't experience pain. Probably should backtrack to note that it's not that I'm happy to share this as much as I'm comfortable sharing that with all of you. And it is also not a black or white thing. It doesn't mean that I never experience pain. It does mean that frequently, while being injured, I'm not aware of it because I don't experience pain in those moments, which is remarkably inconvenient. I know to some people it seems like, wow, that is a really great thing. Trust me, it is not. But it is something that is pretty common amongst people who have this diagnosis. So, more things to look for. Clients can also experience narcoleptic symptoms where they sort of nod off or they get really, really, really sleepy. That can happen right before a switch. It's very common in dissociation. You might notice eyes scanning rapidly around the room or a lot of blinking. That's something else that can happen before a switch. It's really important to understand that switches are not obvious. DID and OSDD are covert disorders. You might also notice in your clients as you're trying to screen that they have difficulty making seemingly small everyday decisions. Figuring out what kind of ice cream to eat, figuring out what clothing to wear in the morning. They may present as being really indecisive, when what's really going on is that there are multiple parts that are struggling inside because they all want something different. This is actually illustrated really well by Jamie Pollock when she was a guest on Adrienne Fletcher's Braving the Way podcast, where she talks about, kind of imagine bringing this van full of people out for ice cream, and maybe there's 20 people, and you can only get one ice cream cone, and all 20 people or however many have to agree on one flavor, but yet, the uncle loves rum raisin and there's a kid that wants vanilla with sprinkles, and yet there's an adolescent that wants mocha and there's somebody else that wants coffee almond, whatever, but you can only choose one flavor. When you are in times that you're trying to make decisions, whether that's what to wear, depending what parts are around and what parts are passively influencing, you can get stuck there for a period of time. And it does look like you are really incredibly indecisive when in fact what you have is this disagreement internally that you don't know how to work out if you were at the beginning of learning about your parts and getting communication in place. And honestly, even after you have that in place, it's not always the easiest thing to do because parts continue to disagree. It's not like all of a sudden all of the parts say, okay, part X, Y, and Z, you're the one that's going to choose what we wear every day. It doesn't work like that. You might also notice as you continue screening that your client has a difficult time remembering how their day was spent, or they really struggle to track from one session to the next. Like they don't remember what you talked about last week. They don't remember what they did as they're sitting in session with you. And you say, how did the week go? And unless they look at their phone or they look at their calendar or they pull out a list, they're unable to tell you. I have often said that if somebody steals my phone, I lose my phone, or it breaks, I am absolutely screwed. And I'm not kidding when I say that. It is an incredibly effective way to compensate for the deficit. Really, really common for people with DID and OSDD. You might also find a discrepancy between the client's history and their presentation. So, for example, they might have a really difficult history that is full of trauma and full of abuse, but they seem to be presenting just fine, and they ostensibly also seem to be functioning just fine. That may be because of dissociated parts, where they have parts that are presenting to the outside world as, quote, just fine. Yet at home, they might really, really be struggling. Be really careful about this particular presentation. It's one that I am particularly sensitive to and about because it is something that was used to discredit and invalidate me. So I would hear things like, but you're an A student, you graduated fourth in your class, you went to Wellesley. They would use a list of my academic achievements to basically attempt to say that my history couldn't possibly be true, or the way that I was attempting to describe my history wasn't true. And yet I suffered decades of unspeakable, horrific trauma. I've already shared that mine went well into adulthood. But the reason that I did so well at school and also in the job that I was working while I was in school was because of my parts and the amnesia between them. It is also why I could be profoundly depressed and even suicidal back in the day and still have makeup on and be presentable in terms of how I was clothed. There's a lot of both and in DID. Okay, now back to other explanations for this discrepancy in presentation by clients. It might be that they're just completely split off. Like they can tell you about their really difficult traumatic history, often with no emotion, and they're presenting just fine because it's not connected. They're split off. As you get to know your clients, you may learn more about passive influence that they are experiencing, that inside their head, they have parts telling them not to say certain things, or that are kind of inserting feelings into them. Like all of a sudden they feel profoundly sad. I could describe times of going downstairs when I have a lull in brain activity and all of a sudden just being overcome with leveling sadness out of the blue. Feels like it belongs to somebody else. People talk about or experience kind of made actions where they are doing something that they don't want to be doing, but they can't not do it. Like they don't have control over their physical body. You can see this in clients with eating disorders who have DID, where internally they're like, I know what I'm supposed to be eating for myself right now. I know what I want to eat, but somehow this other food that is not what I planned on or what I agreed to eat is on my plate, or I can't bring myself to eat, even though I'm trying really hard and saying like, get up, go make the food, go put together a plate, but I'm just stuck on the couch and I can't move. That's something that can get labeled as resistance or unwillingness when in fact the client is in this state where they're co-conscious, they can see what the other part is doing, which is basically refusing to follow through with nutrition, and they're completely powerless. They are in the passenger seat of the car. So be aware of that type of dynamic going on for your clients. Ask about changes in handwriting. For my entire life, I've had different handwriting in notebooks, in letters. To this day, my handwriting varies. I have multiple different handwritings that if you were to pick up one of my journals or even the notebook that I keep for work and lists of things that we do, it's all different. It looks like there are multiple people writing in it. Worth asking about. You might also notice in your clients that they're really engaged in therapy, but they're just not able to make progress. That can be because there is not agreement among parts. So you might be talking about something in therapy, teaching something in therapy. You're looking at somebody who is evidencing that they understand and they're agreeing to make some changes or try to do something different. And yet they kind of come back in week after week after week in the same place. Then the changes are not translating into their daily life. That can very often get dismissed as, again, treatment resistance or reluctance or something else that is generally unflattering, when in fact, it is simply evidence of multiple different parts at play in the person's life. You can also ask about whether or not they are aware of internal noise or conversations. Ask about their thinking. Forever, so many of us have thought that the voices that we hear internally are just our quote unquote thoughts, not realizing that most people, when they think, don't have different voices inside, meaning different vocal tone, different qualities, different ages, etc. You can't know what you don't know. If that's been your experience your whole entire life, you wouldn't know that it's somehow different from somebody else who doesn't have dissociative identities. Worth asking about. Sometimes people will describe hearing noise that sounds like standing outside of a big event, maybe like a wedding reception, so they can hear lots of different voices, but they can't make out exactly what those voices are saying. And other times they're literally listening to detailed conversations and maybe even at the point where they can participate in those conversations. Very often, the only way to find out that that exists is to simply ask. A lot of people won't offer the information because they either think that it's completely normal and everyone else experiences it, or they're afraid that they're crazy. So ask, reassure them that they're not crazy. It's maybe the only way that you're going to find out. Also ask if they've ever found things in their possession that they don't remember buying, or if they've ever sort of stumbled across things that they didn't know that they've done, but it's been done. So, for example, making phone calls or sending an email, something to that effect, or working on a document and then going back in and realizing, oh, I don't remember doing this at all. Very often we can dismiss that as saying, oh, I just have a busy brain. I have a lot going on. You might ask also how other people in the client's life would describe them. How would their family describe them? How would their friends describe them? And see if you're noticing any discrepancies between what they're reporting and what you're seeing and how they experience themselves. It's really important to be curious. Amnesia, which is a criteria for DID, is not obvious at all. If you're losing time, you don't exactly know that you've lost it. It might not make sense to you when I say it that way, but media and the way the DSM is written kind of makes it sound like everybody with DID always finds themselves, quote, waking up in a situation and having absolutely no idea how they got there. That is not always the case at all. Clues of amnesia are things like the person finding themselves thinking, wow, that person has a terrible memory. I wasn't even there. I would never do that. And they might actually not be tracking how often they're finding themselves thinking that. Again, finding things that you must have done, but you have no remembrance of actually doing it. And so, again, you just chalk it up to being distracted or being too busy. Not remembering what you did earlier in the week, like getting to therapy, and you really can't function in therapy unless you bring a list, or you have to look at your calendar to figure out what you did during the week. That's another clue. A person finding themselves thinking that somebody is constantly gaslighting them. For example, they might be asking questions and the person that they're asking questions to insists that they've already had that conversation. And maybe they just had that conversation, but the client doesn't have any remembrance of it. And certainly not remembering what you've done, which we mentioned earlier, like paying a bill and needing to check multiple times and realizing over time that that is actually something that happens really frequently. It's so easy to chalk those things up to just stress, there's a lot going on, or maybe I have ADHD, rather than dissociation and amnesia. Having a sense too that you have done something or that you were in a situation, but you don't really remember it in any detail. And maybe eventually it will like come back to you in this foggy sort of way. That can be a part that's trying to filter information back to you. That's another clue. And sometimes amnesia is missed even when it is glaringly obvious. The person is missing a really big chunk of their childhood or major events in their life. They don't remember their graduation. They don't remember multiple years of their childhood. And sometimes people think, oh yeah, something traumatic probably happened during those years, but they don't even consider, like therapists don't even consider that that is an indicator that a dissociative disorder might be present. So remember, screening takes time. It's noticing things over time. Watch for subtle shifts. So DID is not obvious unless you're pretty seasoned, and even then it can take a while to present itself depending on the person's system and its willingness for you to see the system and the parts in the system. Again, DID is designed to be covert for a reason. If it was obvious, we never would have survived the trauma that it was designed to help us survive. Ideally, you can learn to be a safe enough person in a safe enough environment for parts of a system to present themselves to you. And if and or when that happens, remember that that's an honor. It's actually an incredible honor. If you are a clinician, curiosity is your best friend. Believe your client and make the therapy room a welcoming, comfortable place where all parts can speak and be heard. And reassure your clients verbally that you want to hear from all parts and that you respect them. You may also need to say only one part can talk at a time, because sometimes parts, when they haven't been heard, try rushing to the front and things get kind of gummed up and it's really hard for that information to get out there to you. It's also important to remember that if somebody has DID or OSDD, the likelihood of feeling safe is really low. So strive for safe enough. We hope that helps clinicians who are out there trying to work with people who have DID and OSDD and trying to recognize when you have clients who have that. We will leave some resources for you in the show notes. We've got some great ones for you, like An Infinite Mind, wonderful organization, books like Dissociation Made Simple by Dr. Jamie Marich, lots of different great Instagram accounts. If you haven't seen Petals of a Rose movie, please do watch it, and definitely check out our podcast episode with Dylan and Holly Crumpler. Lots of good info for you. For those of you who have DID or OSDD and you were listening to this episode, we hope that you found some validation in it. Feel free to share it with your providers, especially if you have a provider that is new to treating DID and OSDD, just to give them some ideas of things to look for. And if there are things that you identify with, you can say, hey, I was listening to this podcast and these are the things that Healing My Parts was talking about and it fits for me. That is it for this episode. Thank you so very much for being here. Till next time, let's keep healing. Thank you for tuning in. You can find our blog on Substack at healingmyparts.substack.com and on Instagram at healingmyparts. Just a disclaimer, any information shared in this podcast is not a substitute for professional therapy or behavioral health care, nor does listening to the podcast constitute a therapist-client relationship. Please be sure to take extra good care of you. And until next time, keep healing and thriving.